This lecture will be covering the acute medical management of ischemic and hemorrhagic stroke. This chapter covers the clinical presentation of acute stroke, the initial workup of acute stroke, and then the early management for both ischemic stroke and hemorrhagic strokes, including the different types of hemorrhagic strokes. Overall, stroke is a major clinical and financial burden on global healthcare. Throughout the world, over 6.2 million people die each year due to stroke, leading it to be the second cause of death in people over the age of 60. In the United States, approximately 800,000 people die annually from stroke. Overall, this causes up to $34 billion in healthcare costs each year. Risk factors for stroke include hypertension, diabetes, smoking, atrial fibrillation, and other cardiovascular diseases. For hemorrhagic stroke, the risk profile is different and includes use of anticoagulation and hypertension. Overall, there are high rates of morbidity, disability, and hospital readmission after first stroke. The risk of stroke is higher in patients who have already had a previous stroke. Initial signs and symptoms of stroke are dependent on the type of stroke and the location in the brain affected. In strokes of the anterior circulation, patients typically present with focal lateralizing neurological signs such as hemiparesis, hemisensory loss, facial palsy, or aphasia. For strokes occurring in the posterior circulation, specific cerebellar or brainstem signs can be visualized on patients, such as dizziness, imbalance, and double vision. The clinical presentation first occurs by symptom identification by friends, family, or coworkers. Public outreach efforts by the American Stroke Association have led to an increased awareness of the symptoms of stroke, including their FAST campaign, which identifies facial drooping, arm weakness, speech difficulty, and time. Furthermore, emergency medical personnel are trained to use field triaging tools to identify high-risk patients. Studies have shown time and time again that time equals brain, and the decreased time from symptom onset to ultimate treatment leads to improved functional outcomes. Therefore, stroke code on arrival to the hospital should be smooth and efficient. Patients with stroke-like symptoms should be identified early in the emergency department, and they should be pushed to imaging in a time-sensitive fashion. This will then lead to rapid diagnosis of stroke and also expedite time to treatment for these patients. Now let's talk about imaging options. The initial imaging modality is typically a non-contrast CT head. Specific findings on non-contrast CT head include aspect score, which looks at hypodensities of specific brain regions, which correlates with regions of completed infarct. The dense MCA sign, which is a hyperdense region in the area of the MCA, which is indicative of an MCA occlusion. Lastly, hemorrhage can be obviously picked up on a non-contrast CT head. After non-contrast CT head, vessel imaging is typically obtained. With a contrast-enhanced CT angiogram, specific findings can be visualized that can aid in the diagnosis. These include a vessel cutoff suggestive of a large vessel occlusion, vessel stenosis or intracranial atherosclerotic disease, vasculitis, aneurysm or arteriovenous malformation. Lastly, a spot sign on the CTA can suggest active bleeding into an intracranial hemorrhage. CT perfusion is also used to identify patients who may benefit from endovascular thrombectomy. Perfusion imaging is used to identify regions of penumbra and compare to regions of completed infarct. These penumbra regions may potentially benefit after thrombectomy from restored blood flow. Magnetic resonance imaging is typically not obtained immediately during the stroke workup due to the slow speed of image acquisition. However, it can be used in patients with an allergy to CT contrast. Also, diffusion-weighted imaging can suggest areas of completed infarct that may not benefit from other further therapies. Given that cerebral angiography shows a dynamic imaging, it is the gold standard in identifying vessel occlusion or stenosis. However, cerebral angiography is not typically performed unless a vessel stenosis or occlusion is suggested on non-invasive imaging. Moving on to speak specifically about ischemic stroke. Ischemic stroke is typically caused by occlusion of a specific vascular arterial territory. About 20% of these are due to a large vessel occlusion, such as occlusion of the internal carotid artery, middle cerebral artery, or basilar artery. The remaining strokes in this category are lacunar infarcts, which are occlusions of very small vessels in the brain. Overall, ischemic stroke accounts for 88% of all strokes and are typically either thrombotic or embolic in nature. Initial management for ischemic stroke depends on the time of symptom onset relative to time for presentation. If less than 4.5 hours, the patient is eligible for IV thrombolysis with TPA. If a large vessel occlusion is identified on non-invasive imaging, the patient is eligible for endovascular thrombectomy. Even if patients present up to 24 hours, they may be eligible for thrombectomy if there is evidence of a penumbra on CT perfusion imaging. The key to early stroke management, whatever the cause, is dedicated monitoring in a neuroscience ICU or stroke unit. This includes hourly vital signs and neurological exams in order to detect any decompensation. Clinicians are recommended to target physiological parameters post-stroke. This includes prevention of hypoxia, prevention of hypotension, fever prevention, and targeting a blood glucose range of 140 to 180. Ultimately, several screening tools are employed to improve outcome after stroke. These include dysphagia screening, depression screening, screening for DVTs with ultrasound as a potential cause of ischemic stroke, and lastly, triage to rehabilitation for post-stroke rehab. Now we move on to hemorrhagic stroke. Types of hemorrhagic stroke are separated by location of onset. Spontaneous intraparenchymal hemorrhages occur in 10% of strokes and are typically caused by hypertension, use of anticoagulation, or underlying tumor. Spontaneous non-traumatic subarachnoid hemorrhage is typically caused by either aneurysm rupture or AVM rupture. Initial management of hemorrhagic stroke includes the ABCs of resuscitation. This means ensuring the patient is protecting his or her airway and making sure breathing and circulation are intact. Rapid imaging is critical in these patients, and if there is a hemorrhage on CT scan, to maintain proper ICP control. Lastly, triaging or transferring to an institution with neurosurgical capacity is key. Initial imaging for hemorrhagic stroke includes CT scan, CT angiogram, and potentially a diagnostic cerebral angiogram if an aneurysm or an AVM is suspected. Patients with large intracranial hemorrhages or patients with ICP precautions should be managed in the neurosurgical intensive care unit. Initial treatment options include lowering systolic blood pressure, reversing anticoagulation use, and taking a tiered approach to ICP management, including the use of ICP monitors or external ventricular drainage. Early neurosurgical evaluation is key in order to determine a patient's candidacy for surgical decompression. If a patient has an underlying vascular malformation, it is key to secure the underlying malformation to prevent rebleeding. This is typically done with cerebral angiography and endovascular or surgical intervention. Of critical note, in patients with subarachnoid hemorrhage, delayed cerebral ischemia due to vasospasm is typically seen between 3 and 14 days post-bleed. These patients are given a calcium channel blocker, nimodipine, in order to prevent vasospasm. If vasospasm does occur, hypertensive therapy is often used to perfuse the brain, and in refractory cases, endovascular management with intraarterial verapamil can be administered. In conclusion, the early management of ischemic and hemorrhagic strokes are very similar. This includes maintaining airway, breathing, and circulation per the normal resuscitation pathway, early imaging, early consultation to neurosurgery and neurology, and maintenance of ICP precautions. Overall, outcomes are significantly influenced by taking a multidisciplinary approach. This includes stroke neurology, neurosurgery, neuroradiology, neurocritical care, and rehabilitation teams working in tandem to effect a positive outcome.